All right, everybody, welcome to But What If We Win? Healthcare Edition. What would it look like to have universal healthcare in the United States? We are going to go over the healthcare we do have, how that compares to other countries, and then Medicare for all, Medicaid for all, and some of the policies that I think just have to be absolute yeses, whatever happens. So let us begin. By the way, I'm Zuri Horowitz. I ran for Congress in Congressional District 5. Fighting for universal health care, affordable housing, good union jobs, getting corruption out of government. We are here because it's really important that if Dems win, which they most likely will during the midterms based off of special election results, without the administration completely disenfranchising people, we will need to have a plan. And if we do not have a plan, if we do nothing with the power that we have, we will sink further and further into fascism. All right, let's go. I'm also supporting Julie Gonzalez for Senate. If you would like to door knock, please contact me. Let's get the word out. She's fantastic, as well as David Seligman for Attorney General, Phil Weiser for Governor, and Amanda Gonzalez for Secretary of State. We have some great candidates statewide, and let's make sure we get them into office. All right. So let's set the stage. The US has worse health outcomes than other countries while spending nearly twice as much on healthcare as comparable countries. I will also have all of my sources, and a lot of this I am heavily reading from the sources. This is not all my work. This is my rough draft. I am hopeful that I will get through really major things and have time by the November election to hopefully speak with experts and do a better job of editing and synthesizing the information. I was already able to when the Voting Rights Act was once again destroyed by the Supreme Court, talk about what we needed to do to the Supreme Court in a better way, which would be having an enforceable code of ethics and then impeaching and removing Kavanaugh, Gorsuch, Thomas, Alito, and Roberts, at least, for their ethical violations. And then we could then go and shrink the court, because that has precedent in history. That has happened 4 times for, boldly political reasons. And according to Article 3 of the Constitution, Congress is in charge of the Supreme Court. I'm not saying the exact words, and they are supposed to only serve in good behavior. And if there's one thing about this Supreme Court, they have not served in good behavior. All right, now back to healthcare. So the US has worse health outcomes than other countries. We spend $14,775 per person on average compared to $7,860. Almost $5,000 more than Switzerland, which is a notoriously high-cost country, which has the next highest cost. We live 4 years less than people in our peer nations. For example, the United States has a significantly higher rate of life lost due to heart disease, transportation accidents, and accidental poisoning, which includes drug overdoses. Kids and teens in the US are less likely to make it to adulthood than in peer countries. This is interesting because it might point to not our healthcare system being bad, but our laws being bad and the level of violence we have being a problem. And that's because of high rates of motor vehicle accidents, firearm deaths, and suicide deaths among children and teens. And that has to do with gun policy, which we will get to. We have worse maternal mortality rates. Hospital admission rates in the United States are higher than in comparable countries for congestive heart failure and complications due to diabetes, and some admissions for these chronic conditions could be avoided through primary care. So this is directly quoted from a source. It's in my notes. Hospital admission rates in the United States are higher than in comparable countries for congestive heart failure. Yeah. Okay, we're just repeating ourselves there. And we also have a low number of psychiatrists. So where is that excess spending coming from? This is by a study by the Commonwealth Fund. The US pays more in administrative costs by about 15%. So 15% of it's coming from the costs of administrative costs of insurance. 15% of it is US providers spending more on administrative activities, so that's 30%. We pay 10% 10% of that is coming from prescription drugs. 10% is coming from U.S. physicians earning more. 5% is coming from U.S. registered nurses earning more. And 5% is coming from more medical machinery and equipment. And some of that is, of course, because we don't negotiate it down. So that's 60% of the cost. I don't have the other 40%. So costs are a common barrier to access healthcare in the United States. More than 1 in 4 Americans report skipping consultations, tests, treatments, or follow-ups, and 21% report skipping medication. Only 9.2% of the U.S. population doesn't have health insurance. But because it's so expensive, because there are so many costs associated with our healthcare, people skip treatment. All right, now we're going to go on to what our messy system is made of. Other countries either don't really have a system at all. We have private insurance, Medicare, TRICARE, CHIP, Medicaid, the VA, and then, private insurance. And that all comes together. And because it's so complicated, because we have so many different kinds of systems, it puts us in a higher administrative burden. Also, because we use private insurance and their goal is to provide as little care for as little money as possible, they will often deny care for people. And I don't really get into private insurance that much here today because we know it's bad. We've experienced how bad it is. You know what I will do? I will talk about my experience with private insurance. I have an autoimmune disease. I was prescribed a medication. That medication required that I trial it in office first. I have United Healthcare. Optum is part of United Healthcare and has a pharmacy. Optum decided to put me on as receiving that medication, and they wanted it to be delivered to my home. I could not have it delivered to my home because I had not trialed it in office. Then they took money from assistance from the drug company and gave it to themselves. So what they did was I couldn't access that medication because I had not trialed it at home. But I was now getting money that wasn't mine, but was, and again, when you say, oh, this sounds complicated, I don't know what's happening. Neither was I understanding what was happening. And so they started billing something and trying to schedule delivery of the product that I couldn't have. And that if they are going to be connected with United Healthcare, you would hope that at least they would get the prescription correct, but they didn't. So I ended up having to talk to about 10 people over the course of many days, probably even more than that, to get money that I hadn't even used, to get blocked from having that prescription filled, but meaning that I couldn't really take it. And it wasted my time. I did not get care for that time. It wasted time so that I couldn't get on medication because I was dealing with this and because I couldn't figure out that this wasn't really fully covered and it wasn't the right medication for me. So it took like a month and a half, and that's pretty good for other people, but it took so much time and effort to not get medication and to not make a pharmacy get paid for medication that I never received, that I was not able to use. And that is private insurance. And that's all I'll say about that. There is more in depth about how horrible and stupid it is. Healthcare should not be a for-profit model. The goal of healthcare should be providing health care. That requires a lot of regulation, that requires a lot of input, that requires a lot of fixing and tinkering. It's not a set it and forget it model. So let's get into what Medicare is, let's get into what Medicaid is, a little bit on TRICARE, a little bit on the VA. I don't differentiate that much between them because then we're going to mostly talk about Medicare for all versus Medicaid for all. Thank you for bearing with me. I know that's a lot. So Medicaid covers healthcare costs for people with low incomes. Medicare is a universal program providing health coverage for the elderly. Medicaid is between the states and federal government. Medicare is federal. The CHIP program, which I don't think I mentioned, it's a program that covers uninsured children in families with incomes that are too high to be covered by Medicaid. Medicaid offers elder care benefits not normally covered by Medicare, including nursing home care and personal care services. There are also dual health plans for people who have both Medicaid and Medicare. And if you're like, that's very confusing, that's a lot going on. Oh boy, is it. Is it too much? So let's get a little bit more in depth about what Medicare covers. It's for people age 65 or older. This is from AARP. And lots of sources. None of this stuff is really my words, except if I'm kind of going off on a rant. And it includes 65 or older and younger people with disabilities for Medicare, including those with end-stage renal disease and ALS, or Lou Gehrig's disease. It was started in 1965 under the Social Security Administration and is now administered by the Centers for Medicare and Medicaid. Medicare eligibility is not based on income or assets, and you can't be denied coverage or charged more because of pre-existing conditions. Now, this is what's insane about Medicare to me, and I work as an occupational therapist, and none of this makes sense to me, and it is so overly complicated, and it is why I hesitate around Medicare for all, although we're going to keep going. Medicare is divided into 4 parts, A, B, C, and D. A covers hospital, skilled nursing, and hospice services. B covers outpatient services. C is an alternative that allows patients to choose private plans with different benefit structures that provide the same services as parts A and B. Part D is for self-administered prescription drugs. Is that confusing? Oh yeah. Also, when you do a Google search, now we're going to talk about Medicare Advantage, which is a scam. And when you do a Google search, their propaganda for Medicare Advantage goes straight to the top. Do not go into Medicare Advantage. It is a scam. It does not provide good care. Let's go into why. Medicare Advantage plans are private health plans such as HMOs or PPOs that are offered through health insurers. They provide Medicare covered benefits under Part A and B, and usually provide Part D prescription drug benefits. And sometimes they'll also have like little cute things like eyeglasses, some dental care, or gym memberships. They have limited out-of-pocket spending for services covered under Parts A and B, and may have lower cost sharing than traditional Medicare. However, Medicare Advantage plans restrict the health care providers that their enrollees can see, so they have to be in-network, whereas beneficiaries in traditional Medicare can see any doctor that accepts Medicare without needing prior authorization or a referral from their primary care doctor. See how that becomes a problem? Now we're going to go into this very in-depth myth-busting of Medicare Advantage. There's also something called Medicaid MCOs that add a whole lot on top of, I'm going to pause for a second and look it up, and then I will be back. But we're going to talk about myth-busting for Medicaid Advantage first. So Medicare Advantage is not Medicare. It is basically, 7 large insurance companies account for 84% of Medicare Advantage plan enrollment. This is from cepr.net. And Medicare Advantage plans make money by spending as little as possible, like all private health insurance, on patient care in order to keep as much of the leftover taxpayer money as possible. So it is private insurance supported by government subsidies. It never saves taxpayers money. That is another myth. In fact, according to the Medicare Payment Advisory Commission, taxpayers have spent more on financing Medicare Advantage than they would have if everyone was covered under traditional Medicare. So let's just see. A 2023 study by the Physicians for National Health Program estimate that CMS overpaid MA plans, which are Medicare Advantage plans, between $88 to $140 billion. So whenever someone talks about Medicare or Medicaid fraud, point them in the direction of Medicare Advantage. Point them in the direction of private insurance. Overpayments have also caused all Medicare beneficiaries to pay billions in higher Medicare Part B premiums. Through taxpayer subsidies, Medicare Advantage has been significantly more profitable for insurance companies than the private plans offered to the rest of Americans. They had a gross profit margin of $1,730 per enrollee in 2021, which is more than double their profit margins on the individual market. It is a scam. All right. It does not save Medicare out-of-pocket expenses. It's just a scam. It doesn't improve health outcomes. Let's see. Medicare Advantage plans push patients to more preventative. Let's see. Yeah, there's not a significant difference in health outcomes between Americans enrolled in Medicare Advantage versus traditional Medicare. They will do some more preventative stuff. However, traditional Medicare is more likely to send its beneficiaries to higher rated cancer facilities, nursing facilities, and home health agencies. So you might get to go to the gym, you might have more healthy outcomes that they're wanting you to do, but it doesn't help. Additionally, lower payments can prevent doctors from providing the best quality care. In comparison, around 99% of non-pediatric physicians accept traditional Medicare. So Medicare Advantage is trying to pay less, and so less doctors want to accept it. Their supplemental benefits, again, are not that great. Most Medicare Advantage plans have high coinsurance rates, along with low annual caps on how much insurance will cover. So it doesn't help people with expensive dental, hearing, or vision treatments. It does not lower healthcare, we already know how much profit they have. So if you want to read, this is a really great article by Brandon Novak called Medicare Advantage Myth Busting on CEPR, which is the Center for Economic and Policy Research on their website, cepr.net. I mean, I'm taking from a lot of sources, but that one just goes into it really well. So now let's talk about Medicaid. I have been on Medicaid and I love it. The copays were tiny. It was very easy to see medical professionals and most things were covered. From Wikipedia, Medicaid is a government program in the United States that provides health insurance for adults and children with limited income and resources. Medicaid was established by the Social Security Administration of 1965 as part of the Great Society set of programs that formed the policy agenda of President Lyndon B. Johnson. And this is why elections matter. That guy, not great on everything at all, fantastic for us in terms of our social safety net. And it was significantly expanded by the Affordable Care Act, which was passed in 2010 by Obama. In most states, any member of a household with income of up to 138% of the federal poverty line qualifies for Medicaid coverage under the provisions of the ACA. State participation in Medicaid is voluntary. However, all states have participated since 1982. In some states, Medicaid is subcontracted to private health insurance companies, while other states pay providers, doctors, clinics, and hospitals directly. There are many services that can fall under Medicaid, and some states support more services than other states. The most provided services are intermediate care for mentally disabled, prescription drugs, and nursing facility care for under 21-year-olds. The least provided services include institutional religious health care, non-medical, respiratory care for ventilator dependents, and PACE, so inclusive elderly care, which PACE, we have Rocky Mountain PACE in Colorado Springs, and they do a lot of great work, basically kind of trying to provide, when I went in to learn about it, a nursing home like supports, but people being able to remain in their homes. So, you could go to their location during the day and get a few meals. You could get basic health care through them. So, you could get occupational therapy, physical therapy, speech through them, some vision, sometimes some dental, sometimes. But, so that's not included in Medicaid. That's more Medicare, at least from what I remember. Unlike Medicaid, Medicare is a social insurance program funded at the federal level. And like we said, people age 65 and older and people with certain disabilities under 65 get covered. And we have those 4 crazy things that they have. And so this is the big difference. Medicaid is a program that is not solely funded at the federal level. States provide up to half of the funding for Medicaid. In some states, Counties also contribute funds. Unlike Medicare, Medicaid is a means-tested, needs-based social welfare or social protection program rather than a social insurance program. Eligibility is determined largely by income, whereas Medicare is determined by age. The main criterion for Medicaid eligibility is limited income and financial resources. And the biggest thing to me, besides it being means tested, besides it having that contribution between federal and state, which I think makes it better because you have local eyes on the program versus it just being a federal program that's very much administered centrally, Medicaid covers a wider range of healthcare services than Medicare. And some people are eligible for both Medicaid and Medicare. There's about 6.5 million people. In 2001, 2013, approximately 9 million people. However, now let's talk about the way the Trump administration is ruining people's lives. Here, I'm just going to say the Medicaid work requirements could put 36 million people at risk of losing healthcare. This is from me in my memory, and I have to find the study. But like 92% that are on people that are on Medicaid are either caregivers, working full-time, working part-time, or students. So there's like 8% of people, very small percent of people who are not working. And generally, they're not working because they're unable to. So these work requirements on our already overly administratively burdened system just adds more cost to Medicaid while we're having a cut of about $888 billion over the next 10 years. So that just hurts people. People will die. People who cannot work cannot be asked to work. People in nursing homes that are like on Medicare and Medicaid should not be asked to work, should not be having to prove that they cannot work. So now we'll talk about the VA. This is where I get a little confused. This is going to be based on my experience of the VA. Most people who are enlisted and their families can access the VA. TRICARE is a higher level of insurance. So we're going to contrast the VA versus TRICARE. And it provides civilian health benefits for the U.S. Armed Military Forces, personnel, military retirees, and their dependents, including some members of the reserve component. But this can be really hard. I talked to somebody locally, Paul Wiggins, who served, in combat zones. But because he was part of the National Guard, he didn't qualify for TRICARE, even though he had served in active combat zones, which I would say would make him a veteran, even though he had not been enlisted as one. So TRICARE is the civilian component of the military health system, although historically it also included healthcare delivered in military medical treatment facilities. So the VA has VA hospitals, and TRICARE lets you access care in the community. And it typically is at a higher level. Although I know two spouses who were shot, and TRICARE would not cover them getting shot because they couldn't sue the person that shot them because they didn't have the money, which again speaks to why we need to have universal health care where everything is covered and that you're not shit out of luck because somebody was horrible to you. Yes, now I'm going to go back and talk a little bit more about what I wanted to talk about earlier. All right, one more thing to mention about the VA. 28,000 employees have been cut from the VA, and often people are not applying or are dropping out, even if they weren't fired. And they also the Trump administration stopped bargaining with the VA's union. So they've been facing a lot of cuts, and we will have a future episode about the VA, and I will learn more about TRICARE. I didn't say we would go into that much detail about private insurance, but we will. Wendell Potter wrote an article called from Healthcare Uncovered called 2025 Big Insurance is $1.7 trillion a year. And we're just going to read a bunch from that. So what did they do? They collected almost $1.7 trillion in total revenue, $175 billion more in revenue than in 2025. These are the top 7 biggest health insurance conglomerates. They made more than $54 billion in profits. They covered 10 million fewer people than in 2024. They ramped up their self-dealing by steering more of their health plan enrollees to physician practices, clinics, and pharmacy operations and other clinical businesses they own. Cough my story at the top about Optum. They took record amounts of money from the state and federal government. As a result, United Healthcare now gets more than 77% of its revenue from government programs, even though it covers almost twice as many people in its commercial plans. That said, all of United Healthcare's enrollment growth since 2015 has been in Medicare Advantage and Medicaid. It covered 80,000 fewer commercial health plan enrollees in 2025 than it did in 2015. United Healthcare now classifies approximately 27% of its revenue as intercompany eliminations. That percentage has increased every year as United Healthcare has steered more and more of its health plan enrollees and their premiums to healthcare delivery operations that Optum, its sister division, owns, e.g., again, the Optum pharmacy. So now let's talk about, it's a complete mess. I think it's really important to understand it's a complete mess, and I don't have any mercy for insurance companies. I do not care if they go out of business. So let's talk about some non-negotiables, and then we're going to go into the actual plans themselves. These are things that when I was running, I thought were really important. Every 2 to 3 years, the government should establish standardized costs for drugs and services. So when you go in, you know exactly how much you're going to pay for services. All nonprofit all hospitals and medical centers, including nursing homes, need to be run by medical professionals and be nonprofit/public hospitals that are heavily regulated. So nothing like UC Health that's making over $1 billion in excess profit while being one of the largest debtors in the state. We need to figure out what's going on. This is something that can be a little bit controversial. I believe that we do need sliding scale copays based on income. I think when everything is fully included, even if it's $1.50, even if it's very little, it still means people think about it a little bit before, and sometimes they don't use stuff when they don't need to use it. But not so much, obviously, sliding scale, meaning that they could still access it. And if they, are below the poverty line, there's no copay. We need to include abortion care. We need universal electronic medical records, like in France, where you have a card and you can just go and everyone has the information wherever you go, so that it talks to itself. Your medical record travels with you. When you go to a new medical facility, they have access to all of your medical records. And if health insurance exists, it must be a nonprofit, period. So let's talk about Medicare for All. And I think what's important and why I finally understand why Medicare for All is being pushed over Medicaid for All is because Medicare for All, even though it's shittier, Medicare is worse than Medicaid, at least in the states that I've lived in. And I've lived in California and Colorado, which are two liberal states, which would explain why they have better coverage. It's fully federal. So if you pass it, it goes across to everyone. Medicaid for All, I think, could be a lot better because it is working with the state and the federal government so that you can be more clear about what you guys need locally, and it's not just being administered from on high. So I do prefer Medicaid for All, but then it's something that could be implemented. We'll get into it, but let's go look at John Conyers' bill, and it's the summary of the National Health Care Act as proposed in the 111th Congress. This is from Wikipedia. It includes the following elements. Expands the Medicare program to provide all individuals residing in 50 states, Washington, D.C., and the territories of the United States with tax-funded health care that includes all medically necessary care. That would include primary and preventative, prescription drug, emergency care, long-term care, mental health care, dental services, and vision care. So that would expand what Medicare provides. Again, because Medicaid already exists and provides those things, it might be an easier transition than to Medicare and having to switch it all over. Prohibits although it would be 50 different states, so who knows. Prohibits an institution from participating unless it is a public or nonprofit institution. Awesome. Allows nonprofit health maintenance organizations, HMOs, that deliver care in their own facilities to participate. On the whole, private insurance would be replaced with a new nationalized system for all basic major care. Gives patients the freedom to choose from participating physicians. That's also very important. In institutions, which, given the coverage of the new national system, would be any institution or clinic in the United States receiving any degree of public funding. Okay. Prohibits a private health insurer from selling health insurance coverage that duplicates the benefits provided under this act. allows the private insurer to sell benefits not medically necessary, such as cosmetic surgery benefits, sets forth methods to pay institutional providers of care and health professionals for services, prohibits financial incentives between HMOs and physicians based on utilization, establishes the USNHC trust fund to finance the program with the amounts deposited from existing sources of government revenue for healthcare by increasing personal income tax in the top 5% of income earners, by instituting a progressive excise tax on payroll and self-employment income, and by instituting a small tax on stock and bond transactions, transfers, and appropriate amounts that would have been appropriate for federal public health programs, including Medicare, Medicaid, and the state children's health and CHIP. Taxes would be paid instead of insurance premiums as the government. So like those amounts that would go to those federally funded healthcare programs would instead go to this program. Taxes would be paid instead of insurance premiums, as the government, instead of private insurance companies, would be paying the care under the single-payer health care. Establishes a program to assist individuals whose jobs are eliminated, such as within insurance companies. I don't care. We're not doing that for AAY. Why are we doing that for insurance companies? For people who have lost jobs for insurance companies. I mean, probably it's the better thing, but I really worry that we'll end up paying out insurance companies and losing a lot of money on that. Requires the creation of a confidential electronic patient record system, which would be great. Establishes a national board of universal quality and access to provide advice on quality, access, and affordability. So this is where I like having Medicaid and having all 50 states do something a little bit different, is that I worry when it gets really centralized and some people at the top are deciding what can be covered and what is the best practice, and there's not as much. I would like there to be a little bit more variability so that you can have different interventions if you're in a different state, and like it can be a little bit more nuanced. So like, hey, one state might be really struggling, another state's doing better, we can learn from that other state. Okay. Provides for the eventual integration of the Indian Health Service into the program and evaluation of the continued independence of the VA. The bill covers treatment starting on the first day of the year that follows 1 year after the date of passage. Compensation continues for 15 years to owners of converting for-profit providers for reasonable financial loss. Ew. Fuck that. Sorry, I'm like, stop. They just don't need to be. We have this thing where if you're an investor, you shouldn't ever lose on your investment, but if you're a worker, you can lose your job at the drop of a hat. And yeah, sometimes you invested in insurance and it didn't work out for you. Okay, get another job. We do that all the time with people. You know, I can see like some slight things, but I'm worried that there'll be a lot of money put into people that really shouldn't have that money. And then let's go into Pramila Jayapal's bill, the Medicare for All Act of 2019. It is more detailed, apparently. And then there's also one by Sanders, which has significant differences, including a global budget system for hospitals. Both proposals contain expansive coverage, including long-term care and dental care with no cost sharing, such as coinsurance, deductibles, or premiums, which as of 2019 is unprecedented in the world. See, I do think having some of that money, not a ton, but some, helps us stay invested in the program, and if we notice costs are going up, if we notice that we need care, we're more involved. Under the House version, funding for institutions such as hospitals would be negotiated with regional directors, while individual providers would be paid a fee for service. Value-based pay for performance incentives would not be allowed. I think that's good. HHS would have administrative authority to set various details. The Senate proposal sets out a 4-year transition plan, and the House proposal is 2 years. As of 2019, the Senate proposal did not include any details on how to completely pay for the plan, but Sanders had released a paper listing ideas. I think there is a tax base. We already pay twice as much for health insurance. We just have to have people understand you will be paying more in taxes, but overall you will be paying half as much ultimately for this health care. Yes, so that's where we're kind of at. We talked a little bit about Medicaid for All, why I like Medicaid for All. I'm going to read an article for you out loud from Rose Meltzer, who talks about, we'll just read it. And this is on firehealthcare.com. I don't know a lot about it, but I do like Medicaid. So like this one, take a little bit more with a grain of salt. Let's look at who they are a little bit. Sorry guys. I know you're not perfect, but we're looking at, let's see what Fierce Healthcare is before I read the whole thing, but I do like it. About us. Oh, well, it's healthcare news. Our journalists strive to bring our readers breaking industry news. Our family of publications. I don't know who owns this. I'm not seeing any names that I know, but I don't know who funds Fierce Healthcare. QuestX. So QuestX does. Let's look at who owns QuestX. Let's see. It's like a business-to-business organization, publisher of brands in travel, hospitality, healthcare, real estate, and technology. It is owned by Mid-Ocean Partners. And this is a Midtown Manhattan alternative asset management firm that specializes in mid-sized private equity and alternative leveraged investments. So keep that in mind. It was acquired for an estimated $180 million, and Paul Miller became the CEO. So keep, grain of salt for what I'm talking about here. That's where this is coming from. So Medicare for All has been a rallying cry among Democrats who support single-payer health care, but Medicaid for All might be a more feasible and effective single-payer system, said American University law professor Lindsay Wiley at the Public Health Law Conference on Saturday. For Medicare for All to become a reality, a majority of the House and supermajority of the Senate would need to support it, as would the president. With partisanship running high, that's not likely to happen. Trump's top health officials have preemptively criticized the movement, arguing that such a policy would lead to the program's demise. Medicaid for All, on the other hand, could be reached at the state level via ballot initiative or a simple majority in the legislature. It would need the federal government's blessing, but not necessarily federal legislation. The idea that we would have national level single payer would be pretty radical. So I disagree with that. I just think it would be interesting to do it as Medicaid for All from the federal level. Wiley said, given that Medicare currently covers about as many people as any single-payer health care system in the world. Medicaid for All, though more feasible, is just as laudable, he argued. Not only would it improve access to care, coordination of care, and health equity, it would also be cost-effective compared to the current system. These public health and healthcare goals are inextricably linked. The current system doesn't require private insurances to have enough skin in the game. Wiley added, patients frequently switch providers and insurers lack incentives to prevent churn, but if payers could control safety net investment and care about housing market regulation, it could have broader public health benefits. Of course, the type of proposal is only viable in liberal states like Hawaii, Vermont, or California, although some of the worst health outcomes and disparities exist in red states. It's hard to grapple with the future of Medicaid in those locations right now. Under the Trump administration, CMS has sought to impose worker environments and reduce the number of people in the Medicaid program. It's unlikely that they would, blah, blah. We already know that they're not going to. You are kind of counting on the providers to make expansion happen because they have money to gain from it. Yeah, so his version of this is a lot different than what my version of it would be. Again, I would say let's take the existing structure that we have for Medicaid that is adopted by all 50 states and expand it to universal health care. So that's what I would say, just because it does cover more, and I found it to be much less, complicated, but that's my take. So what is your take? Let me know. We need to have universal health care. It's going to be a pain in the butt. Medicare for All does have a proposal, does have a very clear plan. We can get it done. I think Medicaid for All is also an alternative, and we could just expand the system to include everybody of all income levels. But let me know what you think. And again, making sure that I'm going to go through the things that I think are really necessary. Establishing standardized costs for drugs and services, nonprofit public hospitals and medical centers, including nursing homes run by medical professionals, sliding scale copays based on income, and very, very low premiums possibly, but I think the more important thing is just the copay. including abortion care so that women have full medical care, universal electronic medical records like in France, and health insurance must be a nonprofit if it exists at all. What's your take? And let me know. Medicaid for all, Medicare for all, something I haven't talked about. There are very heavily regulated markets like in Japan where they have a lot of different insurance, and then if you can't afford it, they cover that insurance, and they're highly competitive and highly regulated. I think because our insurance companies are so corrupt, we just need to do away with them. I think that is the case with Medicare for all, Medicaid for all. Like, unless it's something that isn't covered by us, by like our national medical program, we should not have health insurance companies because they are just too corrupt in our country. But anyway, let me know what you think, and I appreciate your time. Bye.